I was asked here this morning to give a little bit of a case study of one of the projects that's being funded by the EMF in this round. And I'm actually representing the GEDI team, and particularly Dr. Elizabeth Marsden, who is the official recipient of the grant. But this has been a very successful collaboration between a number of universities, University of the Sunshine Coast, Griffith University originally, Oshie from QUT and University of Queensland, and the Sunshine Coast Hospital and Health Service. Some disclosures. The project I'm going to talk about has been funded both by federal and state governments. And this is, Anthony was talking about leveraging. We're sort of doing this backwards. We got some big funding, and now EMF are helping us to close the loop, which is a great opportunity as well. I also do some other research with medical devices, but that's got no bearing on today's presentation. So what I'm talking to you today about is the care of frail older adults in the emergency department. And this is something that we know is dodgy. It's hard to do. And I think there's a number of different reasons for this. Number one is that sometimes older adults arrive in the emergency department and it's not the best place for them to be. And there's a number of reasons for that are to do with our healthcare system and how different parts of that are funded by different parts of the government or world. And people sometimes fall through the cracks, but the emergency department is always there and it's always open. So occasionally people end up there when they possibly shouldn't. And when frail older people do arrive, they have particular presentations that maybe we're not very good at educating our junior staff about, and they're complex. They don't necessarily present with the same clinical presentations that younger adults would present. So many years ago now, about 5 years ago, I was having coffee in Nambour with EJ. And she said, now look, I've invited you here because we want to do this research because I know this works. What we're doing in ED works. So I just want you to, show people. And I said, here's the thing, and this is why it's good to have a university involved. You don't actually know it works. You think it works, you hope it works. Let's collaborate on this and get some hard evidence to show that it is a useful intervention. The other thing we did was, the clinicians had designed this model of care for caring for older people in the emergency department. And actually, they developed it based on a range of their own experiences and going to conferences and listening to people. And one of the first things that we did was we actually pulled it apart and had a look at what was the theoretical underpinning for this. And there is a lot of theoretical underpinning for what happens with the GEDI service. First of all, we looked at the nurse role effectiveness model, which talks about how doctors and nurses can make independent or interdependent decisions. And we also talked about why it's important to have specialist nurses in the ED, because specialist nurses recognise things quickly and are primed to make decisions, and they can make them quickly. So what was the model we were testing? It's a nurse-led but physician championed, and that's really important. You need to have a medical doctor who is passionate about this, who thinks this is an important issue in the ED. But we had specialist nurses in the ED who had specialist gerontology background. They understood the ED's requirement for rapid disposition decision making, but they also had expertise in geriatric assessment, and they were skilled in shared decision making. And they had direct referral pathways both back out into the community but also into hospital services. So they had direct referral to geriatricians, orthopaedic surgeons, etc. So we did, from a federally funded project, we did a clinical trial with historical controls. Randomising is hard in an ED, but we did a very large study with historical controls that looked at a whole range of health service outcomes. And whether or not they were changed if the person presented to the ED when the GEDI service was available. But we also controlled for a lot of other covariates in that analysis, all the usual things that might affect outcomes. And basically what we found was that if you were over 70 and you present to ED when the GEDI service was operational, you're more likely to be discharged home from ED by quite a large percentage, up to 40% change, have a shorter stay in ED. If you required admission, you had up to 24 hours less time as a hospital length of stay, probably because you went to your destination ward immediately. You didn't spend a day in a medical assessment unit and people working out what needed to happen. And good news, we weren't killing people by doing this. There was no increased risk of death, and there was no increased risk of representation for the same cause. People did come back for other causes because this is a sick elderly population. But we thought those are pretty impressive results. And in health economics terms, we did a very detailed health economics study that found that there were cost savings in both ED and in hospital admission costs. And while ever you don't really save that money because you don't turn out the lights, you don't shut the wards, you don't sack the nurses, the opportunity costs for the organisation to take in different patient cohorts was rapidly increased, and the worst case scenario, this was a cost neutral intervention, and in fact, in terms of opportunity cost, it was very beneficial to the organisation. So that's great, but we had these phenomenal clinicians, and one of them is here today, Andrea Taylor, sitting at table 6. Wave, Andrea. She's wearing her bright pink GEDI shirt, which means that she is immediately visible in the immense emergency department that is the Sunshine Coast University Hospital. How many rugby pitches is it? It's huge. But the GEDI nurses really stand out because they have these bright pink shirts on, and everybody knows that they can go to them with an issue. But we had these passionate clinicians like Andrea and EJ. Would this work in another place? Because what we know with these kinds of trials of models of service delivery is, yeah, they work fantastically when you have the initial people who are so passionate about it. So I have applied to the EMF for funding to actually do a study of implementation science. So we've adopted a particular approach, the iParish model to implementation. We developed a toolkit as a result of the funding that actually came from the state government. We have a Queensland-specific toolkit for how to implement the GEDI service, but you don't make change by giving people a book. So the iParish model is all about having expert facilitators, so it's spreading that love from these expert clinicians to other clinicians. The initial implementation sites are Cairns and Ipswich. We're also possibly going to include SCU in that, and we do have other sites who are all backed up, but for the actual funded study, Cairns and Ipswich will be the 2 sites. And if you have been in Cairns recently, you will have seen great publicity for the GEDI service in Cairns Hospital. They've been on the local evening news, they're in the local newspapers, it's all very exciting. And we're going to collect all the same data that we did for the original trial so that we can actually expand the trial results as well. So I'd just like to, in conclusion, say thank you very, very much to the EMF. I think it's stunning that they're supporting implementation science as well as clinical science and discovery work. This study has already changed the outcome for individuals in our health service, and the rolling out of this as a research project will change outcomes for this very vulnerable population in the EDs of Queensland. And we're getting significant interest from international sources. We're going over to Aarhus in Denmark in May, and the people from Saskatchewan are coming to us in August to have a look at what we do. So this is a great project, and we wouldn't be able to do this next important stage without the help of the EMF. So thank you very much, EMF.